journals when you are presenting regular cases and then how it is managed, that's much more educative than reading articles, review articles and all. And that way you have started a wonderful series, and now OSCE for PGs, very important. So continue your wonderful work for many more this thing, yeah, from a higher position than what you are at this time. அப்படிதான் சொல்லிட்டு இருந்தேன், but you are able to manage it so well.
Just once.
So now I have to mute myself.
Dr. Madhumita, welcome.
Good evening, sir.
Good evening, Dr. Madhumita.
Good evening.
Good evening, sir.
Dr. Madhumita, நீங்க ஷேர் பண்றீங்களா PowerPoint?
ஷேர் பண்ண ஸ்டார்ட் பண்ணிட்டுமாங்க சார்?
இல்ல just check.
Yes sir, first நான் பண்றேங்க சார்.
நீங்க just check.
இந்த ஸ்டூடண்ட்ஸ் பார்ட்டிசிபேஷன் தெரியுமா சார்? எவ்வளவு நம்பர்னுட்டா கடைசில?
தெரியும் சார், தெரியும் சார். நான் சொல்றேன் சார்.
Yeah.
I'll send the report, sir.
Yeah, once you know, I was wondering because you are doing everything for them, so whether they are present, otherwise they will say it is available in the video, later on we will see. That type of attitude should not be there.
No, sir. YouTube
everything is posted video, no? So everything is available. Sometimes they will think we will see later in leisure. Yeah.
ஷேர் பண்ண முடியுதுங்களா? Dr. Madhumita, are you able to share?
Yes sir.
Share பண்ணி பாத்துங்க. Just open and just see.
Yes sir. Yes sir.
Yeah, that's fine.
Sir? Okay.
Oh, okay.
Screen.
Okay.
The Sangavan sir just join பண்றாருல.
He has told that.
He'll be there.
Join பண்றாரு 2 minutes now.
He and Vijayaravan, they will all come. Akshayani amma வந்துட்டாங்க. வணக்கம்.
Finance minister வந்துட்டாங்களே.
Sir, good evening, sir.
Finance
Good evening. உங்க வாய்ஸ் கேட்டு ரொம்ப நாள் ஆச்சு. ரொம்ப சந்தோஷமா இருக்கு.
Sir, I called you, sir, some time back or 1 hour முன்னாடி.
Thank you so much. Now I had gone for a walk outside. I wanted to come before.
Okay, sir.
Gauri sir, வணக்கம். Gauri Shankar. Thank you for coming in the video. Yeah.
Sir, I'll call you
Vanakkam.
sometime later, sir. One important job needs to be done.
Okay, sure.
Thank you, sir.
வணக்கம் டாக்டர் தாக்ஷாயணி ட்ரெஷரர்.
Good evening, sir.
பின்னாடி பயங்கர ஒளி வெளிச்சமா தெரியுது.
லக்ஷ்மி கடாட்சம் தாண்டவம் ஆனது ட்ரெஷரர் இல்ல
சார். நீங்க சொல்லிட்டீங்க, நான் சொல்லியிருந்தா திட்டு வாங்கிருப்பேன்.
அவர் டியூப்லைட்னு சொல்றாரு சார், நீங்க எப்படி சொல்றீங்க?
அது பின்னாடி தெரியுறத பத்தி நான் பேசல.
கோல் ஸ்பியர்
சார் ஜாயின் பண்றாரு.
திரு சார் ஜாயின் பண்ணோன்னு ஆரம்பிச்சிடலாங்களா?
ஸ்டார்ட் பண்ணுங்க.
ஆமா ஆல்ரெடி 5 minutes
2 minutes 3 minutes
சாரி சார், ஜாயின் பண்ணல கொஞ்சம் ப்ராப்ளம் இருந்தது. பழைய இதுலயே போயிட்டேன்.
நோ ப்ராப்ளம். உங்களுக்கு இவ்வளவு
வணக்கம் சார்.
வெபினார்ல இருந்து ப்ராப்ளம் இருந்ததா? ஆச்சரியமா இருக்கு.
இல்ல நாளைக்கு இது இருந்தது சார், அதுல போயிட்டேன்.
சாரி சார், என்னோட தப்பு தான் அது. நானு
இல்ல பாய்
3 ப்ரோகிராம் ஹேண்டில் பண்றதுனால மாத்தி அனுப்பிச்சிட்டேன். வேற
இல்ல வந்துட்டு சாரி
சார். குட் ஈவினிங் சார்.
குட் ஈவினிங் தாஷாயினி.
குட் ஈவினிங் மை கோல் ஸ்பியர்
சார். வணக்கம் சார்.
ஸ்டார்ட் பண்ணிடலாம்.
சாரி ஃபார் தி டிலே.
No delay. We are worth waiting for Thangavelu's
சார்
problems.
ராஜேந்திரன் இவரு மதுமிதா முதல்ல ஆரம்பிப்பாங்க. நான் I will follow second hour.
சரி சார். ஓகே சார்.
Good evening everybody. On behalf
ஓகே
of
சார். ஆரம்பிக்கலாம் சார்.
சரிங்க சார், அதான் ஸ்டார்ட் பண்ணலாம் முதல்ல. Good evening everybody. On behalf of IAP TNSC and Academy of Pediatric Sciences, I'm very happy to have a different educational exercise today. Normally we would have our postgraduate training presentation, but thanks to Dr. Thangavelu, who has kindly agreed to focus on something which is very important, actually, because with the DNB exams coming up, he thought that this would be a much useful exercise. So we have restructured it to talk about our OSCE in the pediatric examination. So let us start the day's proceedings with pediatrician's prayer by Dr. Dakshani, our treasurer. Over to Dr. Dakshani.
Thank you, sir. குழந்தை மருத்துவனின் இறைஞ்சுதல் எங்களுக்கு முழுமையான குணமளிக்கும் திறனை தாரும். நோயரின் துன்பம் தீர்க்கும் திறன் நமக்கு வழங்கப்பட்டது எப்படிப்பட்ட சிறப்புரிமை என்பதை பணிவுடன் நாம் உணர்வோமாக. எல்லா குழந்தைகளுக்கும் அவர் தம் குடும்பத்தினருக்கும் அவர்களின் சமுதாய படிநிலை மற்றும் சாதி மத பிரிவுகளை பாராமல் நலம், கற்றல், ஈகை, அன்பு, அமைதி ஆகியவற்றின் தூதுவர்களாக என்றும் இருப்போமாக. நம்மால் முடிந்தனவற்றை மாற்றோம், நல்லனவற்றை உள்வாங்கும், மாற்ற முடியாதனவற்றை காரணத்துடன் ஏற்றுக்கொள்ளும். போதுமான மெய்யறிவும் புரிதலும் எங்களுக்கு வழங்குக. உங்களது வாழ்த்துக்களையும் அருளையும் கருணையும் எல்லா சூழல்களிலும் நேரங்களிலும்
There is a sound distortion. Ask them to mute.
மக்களிடையே கொடுத்து அருளுங்கள்.
Thank you, Dr. Dakshani.
Done, sir. Thank you.
On behalf of IAP TNSC, I thank our academic coordinator, Dr. K. Rajendran, and the resource person for the day, Dr. Thangavelu sir and Dr. Madhumita, for conducting this very essential session. Over to Dr. Rajendran sir for taking over the proceeding, for conducting the presidency of the day.
Thank you, Dr. Thiru, and respected our dynamic president, Dr. Suresh Balam, our secretary, and Dr. Thiru, and treasurer, Dr. Dashani, and today's resource persons, Professor Dr. S. Thangavelu. He's currently a director of Pediatrics, Mehta Children's Hospital, and Dr. Madhumita, she's a registrar at Mehta Children's Hospital, and I welcome Dr. Yes, Srinivasan sir, even though he's in the US and he has participated. And once again, on behalf of IAP TNSC, I welcome one and all. It's really it's a wonderful day because we thought of a regular postgraduate clinic we want to conduct, but since DNB as well as MD exam is nearing, and we plan to conduct OSCE session for our postgraduates. And I thank Dr. Thangavelu sir, who has really agreed for this, readily agreed for this program. And once again, on behalf of IAP TNSA, I thank all the central as well as state DP members and other students who has actively participated. And once again, I thank one and all, and I welcome Dr. S. Thangavelu sir. Please take over, sir, please.
Thank you. Thank you, Dr. Rajendran, Dr. Thiru, Srinivasan sir, and all the organizers. Thanks for the opportunity to learn as well as to teach. So my first session will be started by Dr. Madhumita. Usually each session we are trying to finish up between 3 to 4 minutes. We have some 30 to 35 OSCEs. We'll try to provide the maximum. 3 to 4 minutes each one will take. If you get the answers, please post in the chat box. Then we cannot wait for the answers. Post the chat box, we'll follow it up with that. Over to Dr. Madhumita.
Yes, sir.
Slideshow. Madhumita, slideshow.
Yes, sir. Good evening, everyone. I'm Dr. Madhumita. I would like to thank IAP Tamil Nadu State Chapter and Dr. Thangavelu sir for giving me this opportunity. We'll start off with the OSCE session. The first topic will be the easiest one. What is the osmolality of standard ORS and low osmolar ORS, followed by advantage of low osmolar ORS over the standard one. What is the composition of low osmolar ORS? How to prepare Rezamol and the composition of Rezamol? How do you treat dehydration without signs of shock in a SAM child? What are the signs of overload we check while giving fluid in a SAM child? So beginning with the ORS, standard ORS had high sodium content and also the osmolarity of 311. Which is not required in non-cholera cases of diarrhea. So we have reduced, and reduced osmolar ORS is available. The advantage is it reduces the stool output when compared to standard ORS, and also it reduces the duration and the severity of diarrhea. And also there is no risk of hyponatremia. And the composition is glucose is 75, as well as the sodium is 75, chloride -10 is 65, potassium is 20, citrate 10, giving the total osmolarity of 245. And Rezamol is basically rehydration solution for malnutrition children. Basically, the malnutrition children have high sodium content in their body and low potassium. Hence, we have made this preparation called Rezamol, where the sodium content is higher when compared to the standard ORS. We prepare Rezamol by giving water, by adding a 2 liters of water. Where the ORS, standard ORS, one sachet is used, sucrose 50 gram, and commercially available combined mineral mix for Rezamol, which we add 40 ml. By adding this, we get a sodium of 45, potassium of 40, and 40, and chloride 70, and glucose of 125. And along with that, we get citrate, magnesium, zinc, and copper. In a SAM child, we give Rezamol 5 ml per kg every 30 minutes for 2 hours, followed by which we will give on alternate hours by 5 to 10 ml per kg. On the other alternate hour, we supplement them with feeds. What are the signs of overload we look for is raise in pulse rate by 25 per minute, raise in respiratory rate 5 per minute, increasing in the edema, and engorged veins. These are signs of overload. If that happens during the 10 hours or after that, we should stop hydrating the child in SAM. So this is audiogram. Before getting to the questions of audiogram, I'll discuss about the basics of audiogram. In audiogram, the normal decibel is -10 to 20 decibels, the normal hearing, after which we get hearing loss, mild, moderate, severe, and profound. 40 is mild, 60 is moderate, 85 is severe, and more than that will be profound. We will be checking air conduction and bone conduction in audiogram. So while checking air conduction, there will be a sensor in the external ear canal. The sound wave travels from auricle, external auditory canal, eardrum, ossicle, muscles to the vestibular pathway and to the auditory nerve and to the auditory center. But in bone conduction, this transducer will be in the bone platform. So the sound wave will travel from skull, bone labyrinth, spiral to the inner ear and to the auditory center. So air conduction follows external ear, middle ear, inner ear and to the center. Bone conduction directly to the inner ear and to the center. So if there is a defect in the air conduction, there will be defect in sound conduction, air conduction defect. The defect is in sound conduction pathway. If there is abnormal bone conduction, the defect is in sound perception pathway. So how do we interpret audiogram is there are few symbols which we need to know. The red color usually indicates right. So right, red, round. This is a mnemonic where round is the circle symbol for air conduction. Red is basically for the right ear. Blue is for the left ear. And this symbols towards if it the open side is towards the right, it is the right side of the bone conduction. If it is towards the left, it is for the left bone conduction. So this is the normal audiogram. The circles of red shows the air conduction of right side. The crosses of blue shows the air conduction of the left side. So the question is, this is the first audiogram. Comment on this audiogram and the causes for first audiogram. And second question is comment on the second audiogram and the causes for it. And if we perform Weaver's test, which side the localization occurs in different types of hearing loss. So moving to the answers, we'll discuss about the first audiogram. Here we see the normal bone conduction threshold, but the air conduction threshold has dropped down. So there is bone conduction is better than air conduction, which means there is some defective in conduction pathway. And the airborne gap is also increased. When there is a difference in the airborne gap of 20 decibel, it is significant. This is a conductive hearing loss. It is seen for both blue and for the red. So it is a bilateral conductive hearing loss. So for the second one, we'll move on to that. There is a significant decrease in both air conduction, also bone conduction threshold. So it is a sensory neural hearing loss. In sensory neural hearing loss, there is no airborne gap because both are affected. Since both right and red and blue are affected, it's a bilateral sensory neural hearing loss. And also I want to discuss another interesting audiogram. It is called cookie bite audiogram, where it is significantly seen in congenital sensory neural hearing loss. There will be a defect in the mid frequencies, but other frequency will be less affected. Mid frequencies will be more affected, like 500,000 and 2,000 will be more affected. This is the cookie bite audiogram. So answers for the question. The first one is bilateral conductive hearing loss. Conductive hearing loss happens if there is a defect in conduction of sound through external canal. It can happen in atresia, stenosis, foreign body, or cerumen impaction. If it happens in the middle ear, it can be tympanic membrane perforation, or the vascular chain can get discontinued, autosclerosis. For the second one, it is a sensory neural hearing loss, bilateral. It can happen in hair cell destruction with autotoxic drugs or noise-induced hair cell destruction, eighth cranial nerve defect, or syndromes like Alport syndrome, Usher syndrome, and Pendred syndrome. In infections, it can be congenital infections like measles, rubella, toxoplasmosis. Acquired, it can happen in measles, mumps, strep pneumonia, H influenza, and varicella. For Weaver's test, the localization will be in midline in case of normal hearing. For a sensory neural hearing loss, it will be towards the normal side. In a conductive hearing loss, it will be towards the affected side. So moving to the next question, name two indications and contraindication to perform a lumbar puncture. Which space of spinal cord we will drain CSF in lumbar puncture? What is the specific CSF finding in GBS, and explain it. The finding in TB meningitis, how do we differentiate traumatic tap from a hemorrhagic tap? So the indication is we can do for when we suspect a child with meningitis or encephalitis. Encephalitis can be infectious or autoimmune. In case of idiopathic intracranial hypertension, for any demyelinating disorders. The contraindication is when we suspect a space-occupying lesions in the posterior fossa above tentorium or in the spinal cord. It is contraindicated because it will cause herniation. And for the signs of impending, if there is signs of impending cerebral herniation in a child with suspected meningitis, we don't have to do, it is contraindicated, like altered respiratory pattern, abnormal pupil size and reactivity, altered posturing. All these things are signs of impending cerebral herniation. In case of severe thrombocytopenia, we avoid LP. And if there is a abscess or skin infection at the site of where we plan for LP, it is contraindicated. We drain from subarachnoid space. In case of GBS, we expect albuminocytological dissociation, which is very specific, where there will be abnormal CSF protein level with no CSF pleocytosis. The cells will be normal, but protein count will be elevated. The pressure, in case of TB meningitis, obviously the pressure will be elevated along with CSF protein being 100 to 300. The cells will be between 100 to 500 with lymphocytic predominance, and glucose will be low, and CSF PCR will detect MTP. How to differentiate a traumatic tap from hemorrhagic CSF? There will be progressive clearing of blood from the first sample towards the last sample. Here there is a sustained color seen. Here there is progressive clearing. So this shows it could be a traumatic tap. And the second point, while centrifuging CSF immediately, I'm sorry for the delay. While centrifuging the CSF immediately, the supernatant solution will be clear in case of traumatic tap, as you see here, but it will be xanthochromic in case of hemorrhagic. For the additional points, other cause of xanthochromia, xanthochromic CSF could be in case of hyperbilirubinemia and carotinemia. Sometimes in case of when there is high protein load in CSF, we get xanthochromia. So for the next one, what is this drug? What group it comes under? Indication of this drug in pediatrics. What are the available routes of administration of this drug? Name 4 side effects for this drug. It is basically rituximab. It is a monoclonal antibody against CD20 antigen on the cell surface of B cells. We use in pediatrics in case of steroid-dependent nephrotic syndrome, CD20 positive VALL, or in case of non-Hodgkin lymphoma, chronic ITP cases, autoimmune hemolytic anemia, refractory SLE. The route of administration, we have only IV. Subcutaneous route is under development, but it is not used for pediatric cases. The side effects we expect, the most severe side effect is infusion reaction. It happens mostly in the first infusion, so we need to be cautiously monitoring for hypotension, hypoxia, bronchospasm, angioedema, things, and we need to monitor as per the symptom. And when we give in malignancy cases with a high tumor load, we expect tumor lysis syndrome, so precaution need to be taken. We can expect severe mucocutaneous reaction. Rare cases, there is reactivation of B cell infection and cardiac arrhythmia can occur. So we need, for this one, we need to match the criteria or score used for the following condition. For tonsillectomy, what we use. For group A streptococcal infection, pharyngitis, what we use. For atopic dermatitis scoring, what we use. For CRU and asthma severity scoring. For tonsillectomy, we use Paradise score to decide on tonsillectomy. For gasopharyngitis, center score or MECA-ISEC score. Atopic dermatitis, Hanfin and Rajka score, CRU-Weasley score. And for asthma, PRAM or PAS score, pediatric asthma severity score. For the vaccines, we'll discuss on dog bite. What are the categories of dog bite we know? Here, I have a picture of a 2-year-old brought inside the ER with a history of dog bite. And what is your treatment for this category? Identify the category and what is the treatment your plan. And the next question is, if a 10-year-old boy sustained an aberration over the left arm by his pet dog, and he says the dog was vaccinated completely. Do we still vaccinate, or do we have any other plan? We need to discuss about that. And we know there are certain monoclonal antibodies available for rabies. We need to know the name. For the categories, there are 3 categories. First category is no infection, no exposure. When there is a touch or licks on the intact skin, there is no treatment for that. But the category 2 is nibbling on the uncovered skin, minor scratch or abrasion without bleeding. If there is no bleeding or nibbling over the uncovered skin, it is a minor injury where we need to have a local treatment for the wound and administration of anti-rabies vaccine. The third category, single or multiple any transdermal bite or scratches, licks on the broken skin. If it licks on the uncovered skin, it does not matter. If it on the broken skin, it is category 3. Contamination of the mucous membrane with saliva, it is also category 3, where we need to address it severely with the local treatment, administration of anti-rabies vaccine, and rig or monoclonal antibody. For this picture, it is at category 3 bite, where we advise wound wash, local treatment with for the wounds with wound wash, running tap water and with soap for 10 to 15 minutes. Following that, anti-rabies vaccine either through ID route or IM route, whichever is available. If it is through intradermal, 0.1 2-site injection on day 0, 3, 7, and 28. Or if it is through IM injection, it will be 0.5 ml one site on 0, 3, 7, 14, and 28. Along with that, we need to give immunoglobulin or monoclonal antibody for the local infiltration. For the next one, which I asked whether we can vaccinate if there is a category 2 bite for a vaccinated child. Even then, we need to follow the standard protocol. Even if the dog are vaccinated, we don't have to avoid vaccination because there can be vaccination failure in any case. So we don't want to miss the treatment and anticipate for complication. So for category 2, we still give a wound wash with anti-rabies vaccine with either ID or IM route. Available monoclonal antibody is Rabies Shield, which is a human rabies monoclonal antibody. The dose is 3.3 units per kg. And then another one is Twinrab, which is a cocktail of murine preparation of Tocaraviramab and Miromavimab. The dose is 40 international units per kg. Moving to the developmental area questions. Here we can see a child turning the page singly. What we expect, what age can we expect? And if a child draws diamond shape, what is age? If when does the casting begins in a child? If the next question is child becomes dry by what age? If the child when does the child begins to jump for both feet? The answer will be for turning the page singly, it will be by 2 years. By drawing a diamond happens by 6 years, and throwing the object to the floor is called casting. It usually begins by 1 year and it disappears by 1.5 years. Child becomes dry by night. 75% occurs by 3 years, 95% by 5 years. The child begins to jump with both feet happens by 18 years. And for the other drawing related developmental milestone, a straight line by 2 years, circle by 3 years, rectangle, square by 4 years, cross by 3.5 years, and triangle by 5 years. Next question, expand PMJ program. Under which ministry it comes under? It is under. And what is the aim of PMJ? What is the family size and the age limit to avail this benefit? PMJ is Pradhan Mantri Jana Arogya Yojana. It is under Ministry of Health and Family Welfare. It is the second component of Ayushman Bharat scheme. Basically, it is a insurance scheme, health coverage of rupees 5 lakhs per family per year for secondary and tertiary hospitalization for the poor and vulnerable families. Here, there is no age limit. There is no family size restriction. This is done to ensure no one is left out in a poor and vulnerable family. This is the symbol for PMJ. Moving on to the next question. Match the element deficiency with its effect. Manganese, zinc, selenium, chromium, copper, and fluoride. For a manganese, there will be hypercholesterolemia. Selenium deficiency causes Cashon's disease, which causes dilated cardiomyopathy. Fluoride deficiency causes dental caries. Zinc deficiency causes poor wound healing and also dermatitis. Chromium deficiency causes impaired glucose tolerance and peripheral neuropathy. Copper deficiency causes microcytic anemia as well as osteoporosis. Here, name the deficient vitamin of the following causes. When we give polished rice-based diet, what vitamin deficiency we expect? If it is going to be a predominantly maize-based diet, if it is going to be predominantly predominant treatment with INH, or the consumption of raw eggs for a prolonged period of time, if it's going to be with vegan diet. If it's going to be with the first one, I'll answer it. For the rice-based diet, we expect thiamine deficiency, which is vitamin B1. By polishing the rice, the germ cell layer is lost. So we lose the vitamin which is present in the germ cell layer. So that causes thiamine deficiency. Thiamine deficiency manifests as beriberi, wet beriberi with cardiac manifestation, dry beriberi with neural manifestation. If we give predominantly maize-based diet, vitamin B3 is lost. We get pellagra with triple D, dermatitis, dementia, and diarrhea. And if it is with predominantly, if the treatment is with isoniazid, pyridoxine deficiency happens. If there is a consumption of raw eggs for the prolonged period of time, there will be biotin deficiency. In case why it happens means if we give basically biotin is present in yolk. avidin is present in egg white. Without cooking the egg, avidin will bind to biotin and will inhibit its function. So by boiling or cooking the egg, we can destroy the avidin, and biotin is being utilized. If there is a prolonged consumption of vegan diet, we expect vitamin B12 deficiency. This is the manifestation of biotin deficiency, where we expect skin alopecia and also periorifacial dermatitis. So, thank you. Over to Dr. Thangavelu, sir.
Thank you, Madhumita. Many things are new for me. Very nice way of presented the new OSCEs. Can you stop sharing?
Yes, sir.
Rajendran, visible and audible.
Yeah, it's all visible, sir. Students, I think if you have any doubt, I think any clarification, you can post your questions in the chat box, please.
I have to appreciate Madhumita's quality of questions, excellent questions, and she's going to be a future OSCE setters in DNB exam. Wish her all the best.
Thank you, sir. Sir, I have a doubt, sir. This mineral solution is available, sir, to prepare the rhizomol. It's given in books like that. Mineral solution to be added to prepare the rhizomol. It is commercially available?
No, not available. According to my knowledge, of course, it's 2 years old. So
it's not available, sir. You have to separately, you have to get it, sir, from a lab. I think you have to prepare and give it, sir.
One more point I want to add to Madhumita's this thing. Yes, sir. Yeah, this thing, INH can cause niacin deficiency. Antituberculous treatment can also cause niacin deficiency. It's very important. Yeah.
Thank you, sir.
Okay.
See, this is just about introduction to the OSCE. The earlier, before COVID, it was given 150 marks. Clinical case 150 and this OSCE 150 marks, totally 300 marks. It will be around 25 to 27 OSCEs. Observed 5, video 2 to 3, unobserved 20, 21, and rest is 5. OSCE is a beauty of DNB because simultaneously it tests your knowledge and teaches us. Both happen simultaneously. Now, currently, because of the COVID season, since the COVID season 2020, what is followed is a 20 OSCE stations, 5 marks each, 4 minutes duration each. So roughly about, it comes around 100 marks in 80 minutes. So observed stations are not here in the projected OSCE. It is projected from the National Board head office. 20 questions, 4 minutes time for each question, and 5 marks each. Totally 100 marks in 80 minutes. The one rest station after 10 OSCE. Each station may have 1 to 2 sub-questions. Timer also will be displayed on the screen so that you can adjust your timings. Practically, look at the question stem. Sometimes the examiner may be very like an affectionate mother. They give impressive clues from which you can get the answer. Sometimes they will act like a strict father and give minimum or no clue. Still, you have to solve the problem. No negative mark in OSCE. You can provide more than one answer and you will definitely get marks. Suppose there is 4 answers for a developmental milestone. If you write 6 or 7, probably the kind examiner will take only the positive one and give the answer to you, mark to you. And most of the answers should be only in 4 to 5 words because it has to be corrected, not in sentences like a short note. It will be only in 1 or 2 sentences or few words. With this, we will go to the first OSCE. This is a video OSCE. Actually, tetany, I think it's the other part is not played there. So what is the clinical sign observed? Describe. The answer is tetanic cramps and carpopedal spasm characterized by contraction of the muscle that lead to painful muscle cramps. Causes are vitamin D deficiency, hypoparathyroidism, hypocalcemia, hypomagnesemia, hypokalemia, and alkalosis. Calcium ion plays an important role in stabilizing the resting membrane potential. In the presence of hypocalcemia, decreased threshold leading to spontaneous contraction of the muscles, which leads to painful cramps. What are the other associated signs? What are the other signs of the same pathology is Chostek sign, muscle cramp and seizures. A 10-year-old boy is brought in a comatose state following a short febrile illness of 1 week duration. He has icterus and puffiness of face. INR is 6.5. Deeply unconscious. No response to painful stimuli. Hypotonia present. No hysterexis. DTJ not elicitable. So what is the staging? Second question is, what immediate 2 emergency measures you will do? Name 4 important lab investigations. What are the 2 bad prognostic markers? Any etiology specific management, mention any 3. This is stage 4B. We go through the stages. Stage 1 is periods of lethargy, euphoria, reversal of sleep cycle, trouble drawing figures, EEG is normal. Stage 2 is drowsy, agitation, inappropriate behavior and mood swings. Hysterix will be present and fetal hepaticus will be present. Generalized slowing of the waves. Stage 3, stuporous but arousable. Hysterix is present, hyperreflexia, markedly abnormal triphasic waves. Stage 4 is a last one where there is no hysterix, completely areflexia. Here there are 2 sub stages. One is they respond to painful noxious stimuli, it is 4A. The unresponsive it becomes 4B. EEG showed markedly abnormal bilateral slowing, electrocortical silence. This comes under, because this is a child completely unconscious, this comes under 4B. The initial what immediate 2 emergency measures is check capillary glucose and correct if hypoglycemia is there. Give the respiratory support if needed. Connect to the monitor. Secure the IV access. I just given model mark for also in some of the OSCEs. Name 4 important lab investigation. LFT, PTINR decide the severity of the hepatic failure, electrolytes, renal function test, blood culture, and serum ammonia. What are the bad prognostic factors? Age less than 1 year, stage 4 encephalopathy, INR more than 4, plasma ammonia more than 200 micromole per liter. These are all the bad prognostic factors. Any disease-specific management is NSL cyst infection and paracetamol poisoning, acyclovir and HSV infection, lamivudine and in hepatitis B infection, prednisolone in autoimmune encephalitis, prednisolone or other steroids. This is the OSCE and BLS. What are the key BLS components? You have to fill up the blanks. Compression rate in infant and child, compression depth, compression to ventilation ratio until advanced airway is placed, compression to ventilation ratio after advanced airway placement, and minimize the interruption to 10 seconds. And what situation will minimize the interruptions? Compression rate is at least 100 to 120 in all age group. Depth is 1/3 diameter in a child, amounting to 5 centimeter. 1/3 diameter, 1/3 of the chest diameter in infant is equivalent to 4 centimeters. Compression ventilator ratio is 30:2 for single rescuer. When second rescuer joins, it is reduced to 15:2. Compression ventilation ratio until advanced airway placement is 1 breath for every 6 seconds. Once advanced airway is placed, it is reduced to 10 breaths, that is 1 breath for every 6 seconds. The chest compression should be, interruption chest compression should be minimized, should be less than 10 seconds. But there are certain situations you have to give the interruption for ventilation until advanced airway is placed, rhythm check and shock delivery. In these situations, we interrupt the chest compression. For adults, generally, compression ventilation ratio is 30:2 because in ideal in all situations, because cardiac cause is the commonest one. In children, compression ventilation ratio 15:2 is ideal because hypoxic cardiac arrest is more common. But in children, in a single rescuer, very difficult to perform 15:2. That is 13:2 is accepted. When there are 2 rescuers, team is there, it can effectively perform 15:2. One-year-old child present with the grunting. Immediate management, to mention 6 steps: knee chest position, oxygen, morphine subcutaneous or IV. If the child is having hypotension, shock, volume depletion, sodium bicarbonate IV. This is the only situation where even without doing a blood gas, we'll give sodium bicarbonate. Beta blocker, propranolol IV, phenylephrine, respiratory support. Some of the children may have hypoxia where they may need intubation and vasoactive agents if they are needed. Prevention after the episode is controlled, oral propranolol, or it is an indication for surgical correction of the or the shunt surgery. What is 4-score coma scale and its components? Expand the acronym 4. Name the 4 components, various scores in one of the component. In one of the component, we can explain one or various scores. 4-score is used to assess the depth of coma. It is just coming as an alternative to GCS. It has got 4 components: eye response, motor response. Instead of verbal response in GCS, here it's brainstem reflex and respiratory pattern is included. Each component has a maximum value of 4. Full outline of unresponsive score. This is the acronym expanded. Full outline of unresponsive score. That comes as a 4. FOUS. We've got 4 components: motor, eye response, brainstem response, and respiration. We have taken only one component for expansion for want of time. Suppose with the respiratory component, it's got 4 scorings. 4 means not intubated, regular breathing pattern present. 3 is not intubated, but change of breathing pattern present. 2, not intubated, but irregular breathing pattern. 1 is child is breathing above the ventilator rate. 0 is breathing at ventilator rate or apneic. So this is the component of the 4-score. FOUR, 4-score. Identify this device or needle. Name 4 indications for its use in the resuscitation. What are the ideal sites? Any 3. Contraindications, any 2. Complications, any 4. If they ask like a complication, any 4, they given 1 mark, they'll give 0.25 for each complication. This is the intraosseous needle. Indications are any child requiring IV access, but not able to secure within 3 attempts or more than 90 seconds, or hypotensive shock, cardiac arrest, or sometime in status epilepticus. What are the sites in which it can be performed? Is upper end of the tibia, intermediate surface, 2 to 3 centimeters below the tibial tuberosity, distal end of the tibia in the midline, 2 to 3 centimeters above the lateral condyle, sometime in the lower end of the femur. What are the contraindication? In a fractured bone, we can't insert, because once we insert and give the fluid, it will leak through the fracture site. Or when already we have made a previous attempt, one attempt is made and a hole is made in the bone. If we made a second attempt in that, it will leak through the hole. Osteoporosis is one indication where it may be very difficult to insert the needle because it will cause fracture. And there is an infection on the overlying skin, that is also one of the contraindications. What are the complications? Extravasation around the prick, chip fractures, epiphyseal injury, infection causing osteomyelitis, compartment syndrome, and fat microemboli. But generally, complications are relatively lesser if we take precautions. These are the list of toxins and antidotes: iron, anticholinergics, narcotics, warfarin, oral antidiabetic, benzodiazepines, paracetamol, and methemoglobinemia, and INH. What are the antidotes? This is an easy question. Desferoxamine for anticholinergics, atropine, P2AM, narcotics, naloxone, warfarin, vitamin K, oral antidiabetic, octreotide, benzodiazepines, flumezanil, paracetamol, N-acetylcysteine, methemoglobinemia is methylene blue, and INH is pyridoxine. Any form, IV, IM, or even oral may be effective. This commonly we see CT scan in the actually axial plane or the horizontal plane. So some of the structures we must be able to identify, and I just given the numbers 1, 2, 3, 4. Try to identify this anatomical locations. So this is the anterior horn of the midline. You just see the midline, anterior horn of the lateral ventricle. Just below, just posterior to the anterior lateral will be the head of cardiac nucleus. This is 1. Second comes below that comes putamen and globus pallidus. The basal ganglia, putamen and globus pallidus comes this. And third ventricle in the middle. So this is the anterior horn of the lateral ventricle. This is third ventricle. On either side of the third ventricle is thalamus. Remember, third ventricle start with T. Thalamus also T. T and T. So on either side of the third ventricle, there is thalamus. And the internal capsule is between the basal ganglia and thalamus, the internal capsules. This it has been shown in the T2 sequence of the MRI. You can see the third ventricle, anterior horn. This is the cardiac nucleus, putamen, thalamus, and either side of the third ventricle. And this is the posterior horn of the lateral ventricle. Cholera old boy present with 10 days of fever, vomiting, headache, and anorexia. No history of contact. Outside evaluation of tropical infections are negative. No history of contact. BC scar is absent. Vital signs are stable. Is conscious, lethargic, neck stiffness present. Eye, lateral movements are restricted. Deep tendon jerks are brisk. Fundus is normal. Clinically suspect as tuberculous meningitis. The question is, mention the 3 stages of tuberculous meningitis based on the meningeal signs, level of consciousness, and focal signs. So this is the commonly used one. Stage 1 is non-specific symptoms and signs. No clouding of the consciousness, no neurological deficits. It's almost like a fever with, without focus, like we might be thinking in terms of typhoid. Stage 2, child has lethargy or behavioral changes. Meningeal irritation appears in stage 2. Minor neurological deficits such as cranial palsy, 6th nerve palsy may be there. That is stage 2. Stage 3 is stupor or coma, abnormal movements, seizures, severe deficits such as paralysis and posturing. But nowadays, from 2011, the MRC grading system has added a Glasgow Coma scale. GCS 15, no focal neurological deficit, is no meningeal sign, that is grade 1. GCS 11 to 14 or 15 with focal neurology is stage 2, where there is meningeal signs and focal signs may be present. The GCS score is less than 10, coma with severe deficit, and child comes with high ICP with posturing, opisthoronic posture, it is grade 3. Mention, okay, CT findings. What are the CT findings? CT findings are, this is the plain CT, and you can see the dilatation of the ventricles, lateral ventricle as well as the temporal horn of the lateral ventricle and anti-horn are all dilated. In addition, after contrast, we can nicely see the contrast enhancement. Intense enhancement in the supracellular cistern, sylvial cistern, and prepontine cistern. You can see the enhancement following contrast, the same picture after the contrast. This is the classical features to suggest tuberculous meningitis. So hydrocephalus, enhancement of the meninges as well as the cistern and preponderant cistern. It's a feature of tuberculous meningitis. Sometimes we can also see tuberculoma concurrent along with the tuberculous meningitis. Tuberculoma is mostly seen in the children who are undergoing treatment. When repeat a second or third MRI, you can see the tuberculoma. Here you can see the tuberculoma with ring enhancement in the child with pontine tuberculoma in a child with TBM. So tuberculoma, enhancement of the meninges and hydrocephalus are the classical features of TBM. Sometimes it will be also infarct, maybe. We have not forgotten the dreaded days of COVID. So this is a question on COVID vaccines. What is the type of vaccine? Covishield, Covaxin, Pfizer, Moderna, Zydus Cadila, and Sputnik. Covishield is a recombinant chimpanzee adenoviral vector vaccine encoding the SARS-CoV-2 spikes. Covaxin is a whole virion inactivated SARS-CoV-2. Pfizer and Moderna are mRNA vaccines. Zydus Cadila vaccine is plasmid DNA vaccine. Sputnik vaccine is a non-replicating viral vectors. This is again a simple common question. Fill up the blanks. There are 5 generations of cephalosporins. First, second, third, fourth, and fifth. What are the organisms which are covered? And what is the name of the compounds? First generation is gram-positive, mainly is used for skin infections, which are cephalexin, cephadroxil, and cephazolin. This is only for the skin infection we use it. Or sometimes cephazolin is used for post-surgical prophylaxis. Second generation is cover both gram-positive and gram-negative. It's ideal for upper respiratory infection like tonsillitis or otitis media and lower respiratory infection like pneumonia. And this cefuroxime, cefaclor, and cefoxyrin are the second generation cephalosporins. Third generation main character is they have CNS penetration. These two do not have CNS penetration. This is CNS penetration, predominantly gram-negative coverage only. Gram-positive is not that good like a gram-negative. Examples are ceftriaxone, cefixime, cefdinirin, ceftazidime. Fourth generation, in addition to the CNS penetration, it has got a good coverage of beta-lactamase producing Enterobacteriaceae and Pseudomonas, which is example of which is a ceftriaxone. Fifth generation, in addition to all this, also cover the MRSA. So these 2 examples are ceftibiprole and ceftaroline. 3-year-old boy is brought to emergency with the history of consuming unknown quantity of hand sanitizer. Many of our children are very fond of sanitizer because of the color and smell. He is previously a healthy child, no chronic illness, and not on any long-term drug therapy. On arrival in ER, he was drowsy, pain responsive, vital signs are stable, BP normal, warm extremities, pupils normal, saturation was 93, and there was a slightly lower side of the respiratory rate. So questions are, what bedside test you will do, what abnormality is expected. Bedside test is capillary blood glucose because it contains alcohol. Hypoglycemia, one of the important complications which can be identified and can be reversed to improve the prognosis. What are the common ingredients in the liquid sanitizer? Most hand sanitizer products contain combination of isopropyl alcohol, ethanol, or N-propanol or 60 to 70% ethyl alcohol. In fact, they may have more alcohol than the routine alcohol-based drinks. So 1 ml per kg is supposed to be a toxic. A 10 kg child has consumed 2 spoons, 1 ml per kg, definitely it will reach a toxic levels. What are the expected side effects? Mention any 4. CNS depression, respiratory arrest, and often hypoglycemia and hypothermia are the common complication expected. Child is shifted to PICU, child is on saturation monitor and ECG monitoring. What intervention child may require? Name any 4. Correction of hypoglycemia, the IV dextrose, it should be also followed up with checking the blood glucose of the child goes in for hypoglycemia. Monitoring airway stabilization, respiratory monitoring, intubation, respiratory support of the child goes for bradypnea or apnea. Warming up the child because hypothermia is also one of the complications. We might think that why, how the alcohol, the sanitizer and the other product can cause alcohol ingestion is, there are many household items contain alcohol even without our knowledge. Common things are mouthwash liquid, aftershave lotion, hairsprays, windshield wiper fluid, perfume or cologne. All this contains a good amount of alcohol to cause alcohol poisoning. So basically, sanitizer poisoning is an alcohol poisoning. Common things hypoglycemia and respiratory depression. These are the PPE. Ask you regarding PPE. Name any 4 personal protective equipments other than that shown in the pictures. One is valved respirators. We have almost forgotten those things. You know, everybody was wearing different PPEs, valved respirators, face shield, goggles, aprons, and surgical gowns. Who is the name the clearing authority for both triple layer mask and N95R? US FDA and National Institute for Occupational Safety and Health called as NIOSH. What does it mean by N95? What does it mean N? What is the meaning of N? Why this N95 is there? N means not oil resistant for industrial purposes. Because in fact, in these masks were used mainly in the industries where there was N was there. N means oil resistance. So here it is not oil resistant, and 95 means 95, it filters out 95% of the particles from inhaling. That is the meaning of N95. Here it is not oil resistant. That is why N. What are the purpose of 3 layers in 3-layer mask? Inner layer absorbs the moisture from the exhaled air. Middle layer acts as a filter, and outermost layer repels the liquid. What I mentioned 2 factors that can reduce the efficacy of N95 mask. Facial hair, ineffective seal. When the mask is wet or soiled, naturally protective efficiency comes down. What is FOP2 and P2 with respect to PPE mask? It is shown in the picture earlier. It is FOP2. This is mostly marketed in Europe. Is another system of standardizing the mask by the European Committee for Standardization, namely filtering face piece. That is FOP, with ratings of P1, P2, and P3, which filtering capacity is 80%, 94%, and 99.95%. We call this only as a 95. Here the FOP has got 3 ratings, P1, P2, and P3. P1 is 80, P2 is 94, P3 is 99.5 particles respectively. This is again a common condition we see in day-to-day in the OP. We have seen 2 types of oral ulcers. Describe them. What are the causes, differential diagnosis, and what are the management? This is herpangina. Other one is HSV. So herpangina mostly seen as white vesicles or ulcers in the soft palate only. It will usually not more than 5 to 10. Because of severe burning pain, they may not swallow, they may not take feeds. In fact, there will be drooling of saliva will be there. So HSV, where the tiny ulcers, the ulcers may be around 20 to 30 ulcers, each one will be hardly 0.5 to 1 millimeter, mostly seen in all parts of the mouth. As herpangina is only in the soft palate. HSV, herpetic gingival stomatitis, mostly affected all parts of the mouth. Undersurface of tongue, cheeks, soft palate, hard palate, and also it may even overflow into the outer skin. He's mostly seen in the anterior compartment. So anterior compartment is HSV, posterior compartment is herpangina. And in HSV gingivitis, there will be always a lot of lymph nodes will be there, in the cervical lymph nodes will be there. It may also affect the gum and tongue also may be affected. Coming to pedigree, what is this mode of inheritance? Which sex is affected? Here if you see both male and female are affected. This is both sexes are affected. All daughters of an affected male are affected. All daughters of an affected male are. No male to male transmission. Male does not transmit to males, only to female. Affected female can pass to both gender. Affected female can pass to both gender, male and female. Lethal in high percentage of males. All offspring of an affected female has got 50% chance of being affected. Because it is extremely dominant, a male cannot transmit it to the male. Affected female can pass it on to both genders. Common examples are Rett syndrome, incontinence pigmentae, hyperphosphatemia rickets. Some of the offsprings die in the younger age group, die very early, males. What is this mode of inheritance? Which sex is affected? Here, if you look at it, only males are affected. Unlike the earlier one, both males and females are affected. Only males are affected. This is extremely recessive. Males are most commonly affected. Females are the carriers. There is no male to male transmission. No male to male transmission. Only male are affected. Female may be affected in lionization of X occurs, but present with mild symptoms. An affected male can pass it on to his sex to his daughters. Recurrence risk is all daughters of an affected male are carriers. All daughters of affected male are carriers. Sons of a female carrier have got 50% chance of being affected. Daughters of female carrier will have 50% chance of being a carrier. This is extremely recessive. Alport syndrome, Fabry's disease, Fragile X syndrome, GCPD deficiency, hemophilia, DMDR, common examples of extremely recessive. Only mother transmits the disease, but father does not. This happens in mitochondrial disease. If at least one of the parents are always have the disorder, it happens in autosomal dominant. Father to son transmission does not occur in X-linked. More males are affected. Affected sons are usually born to an unaffected mother is XLR. All generations are affected. Both sexes are affected. Male to male transmission can be present. This is autosomal dominant. This differentiate autosomal dominant from X-linked dominant. In X-linked dominant, male to male transmission will not occur. But in autosomal dominant, if you find male to male transmission, this is more likely to be an autosomal dominant rather than the X-linked dominant. Just to break the monotony. Their enthusiasm, activity, and happiness are infectious to us also. This is a peripheral smear OSCE. It's a 4-year-old child present with fever, splenomegaly, and lymphadenopathy. Identify and describe the cells. What are the alternative names? What is the pathophysiology and 2 causes? This is called activated lymphocytes. Now, how do you identify these activated lymphocytes? A lower nuclear cytoplasmic ratio, an irregular nucleus, with or without nucleoli, dark blue cytoplasm, dark red periphery. You can see a large nucleus and also elongated cytoplasm. Cytoplasm is not regular. Both nucleus as well as cytoplasm are not regular. Normally, the lymphocytes are very nicely round nucleus. Here it is irregular nucleus and then elongated cytoplasm. And the periphery of cytoplasm will be appearing more darker. These are all the features. And you can also look for the vacuole-like structure in the nucleus called the nucleoli. So, lower nuclear cytoplasmic ratio, irregular nucleus with or without nucleoli, dark blue cytoplasm, dark red the periphery. What is the pathophysiology? The lymphocyte activation occurs when lymphocytes are triggered through antigen-specific receptors on their cell surface. So they are called as activated beta cells, activated B cells. Synonyms are atypical lymphocytes, Turk cell in dengue, Downey cells. They are all named. These atypical lymphocytes or activated lymphocytes are named after their discoverer. And one more point identification is, you can see that the indentation, RBC causes indentation over the nucleus. Here you can see the elongated cytoplasm and also the larger irregular nucleus. These are the features of atypical lymphocyte commonly seen in infection mononucleus or EBV infection. It can occur, but they are very closely can be mistaken for blast cells. But in blast, the cytoplasm will be very small. The nuclear cytoplasmic ratio will be higher. We see only a thin rim of cytoplasm, unlike in atypical lymphocyte where you will see a elongated large amount of cytoplasm will be seen. Read this X-ray, which is normal. So this is a normal one. The other one is the abnormal one. Can you read the X-ray? Maybe after 5 to 10 seconds, I will show the child. So this is a child. The child has got squint, indicating loss of vision, defective vision. Also has hepatosplenomegaly and myelothysis anemia. So these occurs in osteopetrosis. The diagnosis is osteopetrosis. How do you identify osteopetrosis? If we look at it very carefully, if you take the clavicle, the corticomedullary clavicle as well as the ribs, the corticomedullary differentiation is preserved. The cortex is seen as a thin white line, and then medulla are seen as a slightly grayish. But you don't see a corticomedullary differentiation. It's a completely white opaque as if it's made of a chalk. It's a marble bone disease. So this is even if you look at the humerus also, you don't see a cortex and medulla separately. So loss of distinction between the cortex and medulla is the important one. But what are the problem we will see is, one is a myelothysis anemia, because the foramen, that the auditory nerve and optic nerve pass through the skull foramen, because of thickening they are narrowed, causing compression of the auditory nerve and optic nerve, leading to defective vision blindness. The thickened bone compresses the marrow, leading to myelothysis anemia. DD for dense bone is osteopetrosis and pycnodysostiosis. In osteopetrosis, usually both have dense bones. But in pycnodysostiosis, two different findings are also included. In osteopetrosis, distal phalanges are preserved. Here, the distal phalange will be lysed. There will be destruction of the distal phalanx. And the angle of the mandible is obtuse angle. These two features, in addition to the dense bones, is in favor of pycnodysostiosis. We have very important differentiating point between achondroplasia child or a serious lethal dysplasias is they are more likely to get into ICU and die. A newborn baby looks like achondroplasia, usually normally not lethal, but there are severe distress recovery resuscitation. You should think in terms of other lethal dysplasia, which are thanatophoric dysplasia and Jones syndrome. So how will you identify them? Thanatophoric dysplasia, thanatophoric means death loving. So these children, even though they look like achondroplasia, they're likely to die mostly in the newborn or early infancy, similar to achondroplasia. But the differences are shorter ribs, micromelia. So micromelia means all portions short with bent bones. In achondroplasia, only the proximal bones will be shorter. Here, if you look at that, both proximal and distal group of bones, both are shorter. And you see the shorter ribs, squared pelvis, limbs, and very short tubular bones. If you look at the tubular bones like a humerus and femur, it looks like our olden days. It's not a French telephone deformity. Even we had the telephone, BSNL telephones were looking like that only. So telephone like short tubular bones, femur and humerus, and then short ribs, extremely narrow thorax, and mesomelia, both proximal and distal bones are affected, is in favor of the thanatophoric dysplasia. So coming to Jones syndrome or asphyxiating thoracic dysplasia, here you can see the bell-shaped chest. Normally, the shape of the chest will not be bell-shaped because in the diameter of the upper half and lower half almost will be similar, but here it will be narrowing of the upper half, resembling a bell-shaped chest. And then mesomelic shortening, see shortening of the leg bones, post-axial polydactyly, and then another important feature is irregular acetabular roof. So these features suggest that it is a Jones disease. Here there is no bending of the bones. So bending of the bones, short rib and thin chest is in favor of the thanatophoric dysplasia. No bending, but it shows leg bones are shorter, bell-shaped chest, post-axial polydactyly, and then the irregular acetabular roof is in favor of syndrome or asphyxiating thoracic dysplasia. This is a 3-year-old boy brought in altered consciousness. They are looking irritable, tachypneic, and cyanosed. The history is he was given fish in the nose. Next few hours, mother was busy and not sure about whereabouts of the child. He was found unconscious outside his home in the evening. Very prominent finding is the cyanosis, and saturation is 86%. In generally, to cause cyanosis, there are only 3 causes: respiratory or cardiac. Or here, the respiratory status is stable because child is breathing well, and cardiac, there are no murmurs, and the child did not have any clubbing also. This made us to think that the alternate possibility is something different. So what could be the third cause of cyanosis? Probably most of you know of it. Apart the respiratory and cardiac status are normal, the child has got cyanosis. What is the third important cause of cyanosis? Probably somebody would have posted in the chat box also. Anybody has posted? Another clue is this is a sample, blood sample. This is the control blood of the mother. What you observe here is a chocolate brown color. This again suggests that we are dealing with some abnormal hemoglobin like methemoglobinemia. So, what is saturation gap? Normally, the saturation in the pulse oximeter and the arterial blood gas both will be similar, or only a difference of 2 to 3, but here the difference is huge. 86% saturation in the pulse oximeter, but if you look at the arterial blood saturation, 99.7%. That means you have a low saturation in the pulse oximeter, normal saturation and arterial saturation. If you find a picture like that, it is indicative of abnormal hemoglobin. Most common abnormal hemoglobin is methemoglobin. The question may come like that. So what do you suspect? How will you prove that by the bedside investigations? So here, the methemoglobin level is available in the co-oximetry, 35.8. So another question also may come as what is co-oximetry? Co-oximetry is a way of checking the abnormal hemoglobin in an ABG sample. That's called the co-oximetry. So co-oximetry can bring the abnormal hemoglobin levels very fast. Within 5 minutes, we can get it. So methemoglobin level was 35.81%. So what are the sources? Sources are, these are the sources: naphthalene, dapsone, local anesthetic creams. It can lead to, how do you manage that child? Main management, they won't respond to oxygen. IV methylmalone is the drug of choice. 2 mg per kg, you can give it over 15 minutes. We can repeat it every 4 hours to a maximum of 7 mg. And the last question is, what precautions you will take before starting IV methylene blue is, we have to check the GCPD levels, because GCPD deficiency is one important situation where the IV methylene blue can lead to hemolysis by itself. This is the question borrowed from my friend Dr. Nidinjalian. Mention the best study design for each of the problems. If you want to study the SAM in Chennai, prevalence of SAM in Chennai, what is its good study design? Clinical course of H&N viral infection. We have a lot of children coming with viral pneumonias. We want to study the clinical course of H&N viral infection. What study design? Efficacy of ciprofloxacin versus ceftriaxone in typhoid fever. Role of USC chest in diagnosis of pleural effusion and pneumonia. Spectrum of clinical presentation and maple syrup urine disease. So, prevalence of SAM is cross-sectional survey. Clinical course of this cohort study. Efficacy of ciprofloxacin against this randomized control trial. And then role of ultrasound chest in the diagnosis of pleural effusion. You compare with the X-ray chest and CT, and there is a descriptive study. Spectrum of clinical presentation of maple syrup urine disease by case series. 27 days old child, excessive sleepiness, look like a good child, does not even cry for feeding, lethargic. So, thyroid profile was done, TSH was high, 900, free T4 is low. So, what is the diagnosis? What investigations are required? Ultrasound of the neck, technetium-19 thyroid uptake scan to identify hypoplasia or aplasia of thyroid. X-ray lower femoral epiphyseal. We was not done earlier before we are able to check the thyroxine level. Nowadays, we don't do the X-ray femoral epiphysis because thyroxine levels are freely available. Treatment is thyroxine oral 10 to 15 microgram per kg per day. What complication are late diagnosis? If you don't pick up the child very early, we diagnose it after 3 months. What are the complications of late diagnosis? Prolonged jaundice, developmental delay, mental retardation, and short stature. What are the complications of excessive dosages can lead to craniosynostosis and advanced bone age and ADHD? Very rarely we might come across the ECG picture or video of arrhythmias. 6 months old child with septic shock, peritonitis, acute kidney injury, and hypertension emergency. Child is receiving some drug infusion. Child is on ventilator support. Each word you have to remember. Child is on ventilator support. Child had hypertension emergency, receiving a drug infusion. Suddenly, child developed bradycardia. Any child on ventilator support develop bradycardia is a very, very serious cause. Serious causes. What are the possible causes? No, we think about dope, displacement of the tube, obstruction, or pneumothorax, or malfunctioning of the machines. So these are all the common causes if it is due to respiratory cause. But if you look at the monitor, the very interesting, reassuring thing is child has bradycardia, but look at the saturation, 97. So that means our child does not have any respiratory problem. We will not be in a hurry to put a needle in the chest for pneumothorax or change a tube or doing suctioning, because saturation is quite very well. So from the saturation, we come to the cause is not a respiratory cause, it's a cardiac cause. Now I will play the video, you can look at it. So for you, I just frozen the video and then played again. If you look at it carefully, there was gradual prolongation of the PR interval. See, the PR interval is prolonged. Gradual prolongation of the PR interval, and then finally one QRS dropped. So gradual prolongation of the PR interval, and then one QRS dropped. You see only one P wave here, only one P wave. This is a classical feature of second degree heart block type 1, where the PR is progressively prolonged, leaving a QRS to be dropped. This is called Wenckebach phenomena. First degree is PR interval alone is prolonged. There is no dropping of the QRS. In second degree, there will be a dropping of the QRS. PR is prolonged gradually and then dropping of the QRS is type 1. In type 2, all are non-phenomena. There won't be any gradual prolongation. Suddenly one QRS dropped. Which is more dangerous? Type 2 is dangerous because invariably it may require pacemaker insertion because block is at the level of bundle Achilles. In type 1 is reasonably safer. It can even respond to atropine, or even if we remove the incriminating factor, the type 1 may get normalized. Here it is a type 1. Exactly, are you able to guess the cause, etiology? Child was on drug infusion for hypertension emergency. Child was on labetalol. Once labetalol is stopped, automatically the arrhythmia got corrected. So this is in the ECG, you see the gradual prolongation and then dropping of the QRS in type 1. In type 2, see the random dropping of the QRS. There is no gradual prolongation. This is a MRI picture. This is a child present with hypotonia and developmental delay. Hypotonia. So like an atonic CP, hypotonia and developmental delay. Look at the findings. The arrow is already marked here. So focus on this finding of the brainstem. What do you see here? So this is T2. This is the Plar image. So finding and diagnosis is the molar tooth sign called in Joubert syndrome. The clinical presentation is hypotonia, developmental delay, episodic tachypnea or apnea, and atypical eye movements. Truncal ataxia can develop later. Associated problems are retinal dystrophy, renal disease, ocular colobomas, ocular encephalocele. These are all the other abnormalities, even endocrine abnormalities may be there. So how does the molar tooth sign develop? Because a deep of the interpeduncular fossa is deeper, and then thick and elongated superior cerebellar peduncles, hypoplasia of the cerebellar vermis, all these lead to molar tooth sign, which is identified in 85% of the patients with Joubert syndrome, which is pathognomonic of Joubert syndrome. Another MRI, 4 months old child with a developmental delay, seizures and dysmorphic faces. You can see the, so what do you observe? Figure of 8 appearance, and then loss of sulci and gyri. It's a normal brain. You can see the sulci and gyri. Here there is no sulci and gyri. It is almost smooth with figure of 8 appearance. Extremely smooth cortical surface with poor development of sulci and gyri, resembling the fetal brain at the end of the first trimester. Diagnose lissencephaly because it is a 4-layered cortical mantle instead of a mature 6-layer mantle. Clinical presentation, they have an extreme development delay, microcephaly, hydrocephalus, intractable seizures including infantile spasms. Rajendran, can we discuss the thing at the end of that? Questions?
Yeah, we can continue, sir. No problem, sir. We can
So what are
continue.
the effects of technical errors in the sampling and the remedy? If there is a delay in processing the ABG, the patient is frightened and started crying, sample mixed with air bubbles, syringe filled with heparin, plastic syringe versus glass syringe. These technical factors, how does it affect the causes the abnormalities in the ABG interpretation? The delay in processing leading to PO2 decreases and PSO increases because the consequence of the RBC metabolism. RBC started consuming oxygen and so PO2 decreases and PSO increases. How to avoid that? Store the sample at 4 degrees centigrade with ice cubes. If there is a delay in transferring the sample of more than 30 minutes to the lab. Patients frightened, anxiety and hyperventilation lead to fall in the PaCO2, respiratory alkalosis. Application of topical anesthetic agent may reduce the pain and related sampling error. Sample mixed with the air bubbles after 2 minutes of air bubbles would lead to increase in PaO2 and decrease in PaCO2. Once you see air bubble, we have to expel the air bubble before you cap the needle tip. Syringe filled with heparin. Dilute the sample leads to falsely low PaCO2 and low pH. Heparin is acidic, so it causes low pH and low PaCO2. So generally, excess heparin should not be taken. We have to take the heparin and expel all the heparin. Whatever is remaining in an empty syringe is enough to prevent clotting. So what is the difference between plastic syringe versus glass syringe? The difference is relatively higher oxygen permeability of the plastic. The outside atmospheric air can pass through the plastic and increase the PaO2. Can be minimized by analyzing the sample immediately or at least within 15 to 30 minutes of sampling to avoid the passage of air from atmospheric air across the plastic wall of the syringe. This is about the inclusion bodies. What are all the inclusion bodies we see in RBCs? Common inclusion bodies are Heinz bodies, Howell-Jolly bodies, Pappenheimer bodies, and Besopelli stippling. These are the common 4 things we see. The 4 bodies. Now, how do you analyze them? So usually the Besopelli stippling and Pappenheimer bodies are multiple, but Howell-Jolly bodies and Heinz bodies are single. So depending on whether they are single or multiple, you can find out. And then the location also will be helpful. If you see the Heinz bodies will be sitting at the wall of the RBC. See here, they are sitting at the wall of the RBCs. But Howell-Jolly bodies are also single, but they are not in the wall, just inside the RBC, just inside the RBCs, not in the wall. And again, the Heinz bodies are identified only by when you use the supravital sign, like what you use for the reticulocyte count. So that's why we don't see any WBCs. The color also will be different. And there are multiple. There are 2 possibilities. One is the Pappenheimer bodies, another is the Besopelli stippling. Besopelli stippling usually will be a punctate, regular dot-like inclusion bodies will be seen. But Pappenheimer bodies are irregular. Pappenheimer bodies indicate a composed of decomposed iron and ribosomal DNA seen. Here they are irregular dots, but Besopelli stippling is usually a aggregate of ribosomes seen as a single fine dots. So Besopelli stippling, Pappenheimer bodies, Heinz bodies, and Howell-Jolly bodies. We can identify them by a number where they are situated, whether they are regular or irregular. Sometimes we might mistake giant platelets for any inclusion body. Giant platelets are loose membranes, fragmented membranes, and maculated size of the RBC. This is giant platelets. Here is a nucleated RBC, may be mistaken for other lymphocytes or other cells. The only difference, we can look at a cytoplasm. Cytoplasm is red, pink like other RBCs. And the dense ink dot like nucleus will identify the normoblast, the Howell-Jolly bodies. Identify named problem. What you see here is extensive necrotic hemorrhagic crest. Eyes are closed, peeling of the skin, and then symmetrical appearance, and there are blisters are seen. This is Stevens-Johnson syndrome at 10. Symmetrical, high fever, extensive hemorrhagic mucosal lesions. At least 2 mucosa should be affected. Oral here, if you look at it, the oral cavity is affected and also eye is affected. You should also look at the perianal region and the penile mucosa, genitalia mucosa. two mucosa should be affected. It should be symmetrical, high fever, extensive hemorrhagic mucosal lesions, high oral genital, bullous lesions in the skin. Target lesions may be seen in early stages. Involvement of the palm and soles. Nicholson scan will be positive. What are the common causes? Sulfa and anticonvulsants are the common causes. Carbamazepine, phenytoin, barbiturates. Sometimes my infection like mycoplasma or herpes virus also can lead to Stevens-Johnson syndrome. What are the pathophysiological consequences? Extensive keratinocyte death resulting in widespread exfoliation of the skin at the dermo-epidermal junction. Management, eye care, sterile saline cleaning, antibiotic early steroid eye drops, nostrils to be cleaned, mouthwash several times a day with saline. Wound care. Nowadays, the immune suppression, immune modulation to some extent helps by using IVIG and cyclosporin are used. With that, the prognosis becomes good. The initial stage, they can go for a complication like upper airway obstruction requiring intubation ventilation. So we come to the end. And I'll just provide a list of OSCEs. We can take a photograph so that it will be useful. When you prepare it, see whether it is whether you covered this or not. Observe stations, of course, PALS, NRP, development stations, procedures, counseling a child with febrile seizure, hemophilia, breaking the diagnosis, Down syndrome child, or a child with migraine, constipation, or history taking in febrile seizures, hemophilia, or any clinical cases. Clinical exam, focus examination like PGALs. So examine the respiratory system or examine the motor system of the lower limbs. So these are all the observe station where when you are doing PAL, when you are doing an OSCE, you'll be sitting only with the paper questions kept there. In addition to that, examiner will be there. You'll be sitting like a statue. He won't react to you. He won't answer anything. He won't even look at you and smile. This is observe station where you will observe your way. How do you examine? How do you do the counseling? Everything, and he will award mark. But because of the current situation, observe station may not be possible because the OSCEs are projected from the head office. But they can alter this and ask in a different way. For example, development, they can ask, okay, write down the developmental milestones of 1-year-old child. Or how do you counsel a child with febrile seizure? Write down in steps. They may expect some 10 steps. So instead of you do counseling with a volunteer, probably you may have to counsel. So observe station cannot be completely forgotten. This may be asked in a different way to write down these steps. Unobserved stations are equipments like what I showed as the intraocular needle. Here they may ask about bag mask ventilation, Rini-Weber test, nebulizers, research biostatistics. A lot of scopes are the sensitivity, specificity, PPVR, sparse plot, chi-square, student t-test, health programs. All the health programs you must be familiar. Invariably, at least 1 or 2 health programs will be asked. Infectious disease covered as common conditions like measles, scrub, dengue, hepatitis, EBV, malaria, HIV. Metabolic disorders like galactosemia, urological disorder, the Ray's syndrome. Rheumatology, they may ask about JA, vasculitis, SLA, Kawasaki. Even MISC was asked earlier. ENT and ophthalmology, fundus examination. Probably fundus pictures may be given. Cherry-ridden fundus or tympanic membrane when you examine with the otoscope. That picture also may be shown as for making diagnosis. Dermatology, hyperpigmented patches, Stevens-Johnson syndrome like this. All this can be asked. In gastroenterology, mostly ORS, diarrheal dehydration, inflammatory bowel disease like Crohn's disease, celiac disease, malabsorption syndrome, GERD. Question may be around case scenarios, may be around these conditions. Cardiology, they may ask one situation. They have just graphically drawn the heart sounds, identify the heart sound, lead one, the first sound, second sound, opening snap, and ejection click, and diastolic and systolic murmur, panstolic murmur, systolic murmur. You will be asked to identify and write the murmur, type of murmur. They can give a case scenario and give an X-ray and ECG and ask you to make a diagnosis whether it is ASD. Suppose we see a child with right axis deviation and then a child having a bundle branch block, you can come out with the diagnosis of ASD. Or the child has got a Cat-Swetzel phenomena with a RS ratio going more than 45. Will be considered as VSD. And syndromes, cardiac failure control, time of surgery, cardiomyopathy, all this may be asked. ECG, invariably 1 or 2 ECG may be there. Probably in the next one, we will cover the ECGs. Nutrition, they can ask about vitamin A deficiencies, zinc, iron, iodine, breast milk. Immunization, all about immunization, schedules, various strains, catch-up vaccinations, adolescents, and adverse reactions against following immunization, growth and development, growth charts to match age with the development. Development OSCE will be very commonly asked when the observer station were available. Endocrinology, invariably there will be 1 or 2 endocrinology questions because they will be all based on mathematics like diabetes insipidus, DKA, technetium scan of thyroid, cerebral salt wasting syndrome. In pulmonology, spirometer, we will be asked to use how we use a rotahalar, PEFR. Seen a case today about asthma. In hematology, smears, very rarely they kept bone marrow. Mostly peripheral smears are kept. Peripheral smears, chemical electrophoresis. Only once year, 1 year, then 2020, there was the bone marrow cereblastic anemia was kept. A very rare condition was asked. Nephrology, commonly they ask about MCU pictures, DMSA picture, and case study and UTI, cystograms. Neurology, there are a lot of scopes are there. You can ask about Weber and very commonly asked Weber test. And then neurofibroma pictures may be seen. Antiepileptic side effects, indications may be there. Nowadays, at least one EEG is asked. EEG, of course, may not be relevant to us, but still very common EEG, like 3 per second spike waves, like that common EEGs we must be able to identify. Neonatology is one of the very important one, giving more mark. NRP will be given more than 10 to 15 marks. So they can ask for neonatal jaundice, temperature control, vitamin K deficiency, RDS, kangaroo mother care. Pediatric surgery also will come like omphalocele, diaphragmatic hernia, interception, valvulus, pictures may be shown. ER and PICU, invariably, at least 1 or 2 questions there in pulse, ER and PICU, shock correction, case scenarios, asthma. Observed station, usually the BLS, cardiac arrest revival will be asked. Snake and scorpion envenomation, poisoning case scenarios. ABG will be 1 or 2 ABG will be there. ABG, fluid electrolytes, hyponatremia, hypokalemia. Capnography, nowadays capnography is being asked. You can see, identify the various curve of capnography like asthma, all that may be asked. Shark fin. Toxicology, at least 1 or 2 poisoning will be there. We will cover more poisoning in the next one. One drug will be asked invariably, like maybe a common drug like adrenaline or adenosine, amiodarone, or a rare like rituximab or anakinra may be asked. Neuroimaging, CT-MRI, at least 1 or 2 will be there. Mostly commonly, hemorrhage, subdural hemorrhage, extradural hemorrhage, ADAM, tram tract calcification of Serge-Weber syndrome, neurofibroma, neural migration disorders, X-rays, rickets, lead poisoning, pneumothorax, obstructive emphysema, MPS. ECG, commonly different types of arrhythmia, torsade pointy. Alcapa, dextrocardia are commonly kept. Genetic syndromes, pedigree chart and syndromic appearances, phases you will be asked to make a diagnosis. So these are all the common things covered in OSCE. We have come to the end. Are we going to go further for some more OSCE? Means I can show that. This is the OSCE. Thanks to our PG Dr. Rahul. This is the last recent OSCE conducted in March. This is the question. So this will give an idea about how this was covering. The curve was given with a Kaplan-Meier curve, forest plot, X-ray finding, diagnosis, and then a video OSCE of supinata reflex, waddling gait, high stepping gait. There was a prevertebral tumor asked about. These are the questions surrounding that. Different types of respiratory pattern, bias pattern, neurogenic hyperventilation, chain stroke breathing. And then they given a case scenario of a child presenting with jaundice and triangular faces, Alagille syndrome. Describe the facial features, pathological finding in liver biopsy, common cardiac lesion, gene involved, and bony deformities. And then EEG pattern, they given PLUTS EEG, indicative of herpes simplex and encephalitis, name and diagnosis, lobes of brain involved, what are the 2 drugs used in treatment, and DD for EEG. ECG, last time I think they given tetralogy of Fallot ECG, tall, P waves, P pulmonale, RVH, right axis deviation, suggestive of P pulmonale, diagnosis, clinical diagnosis, DD for the ECG, Fallot's physiology components, and then surgical approach. This is about HLH. They given an image of histology, HLH biochemical features, cytokines and HLH, diagnosis and treatment. This is about hypokalemic periodic paralysis, diagnosis, mutation, pathology. Next, electrolyte abnormality commonly seen, which is hypomagnesemia. AVG scenario may be metabolic acidosis, And they may ask about oxygenation formulas, oxygen index, oxygen saturation, OI, oxygenation index, oxygen saturation, OSI, AO difference, indication for ECMO for OI, complication of the ECMO. These are all the questions asked earlier. Can we finish it or show some more? We will try to answer the questions. Rajendran?
Yeah, yes, sir. Yes, sir. Please, sir.
So, question and session.
The questions, we have two
Ah.
questions, sir.
Yes,
In rabies vaccination, if the child is already vaccinated, should we give the entire vaccination schedule?
Generally, already vaccinated means there is no need to give immunoglobulin or the monoclonal antibodies. But still, we have to give 2 doses. We have to give. Only advantage
On
is
0 and 30.
yeah, 0 and 13 or 0 7. I think. So only advantage is we need not give a costly one like immunoglobulin or monoclonal antibody if I need it. That's what Madhumita, anything?
Yes, sir. Yes, sir. On 0 and 3, and we don't have to give immunoglobulin or monoclonal antibody because it interferes with the anamnestic response that is already present because of the
And already they
previous
may have
vaccinations.
immunoglobulin because already received the vaccine, they will definitely have immunoglobulins.
Yes, sir.
And, which one is this question, Dr. Das? Can you unmute and ask?
This question was raised
Hmm.
when there was when we were discussing X-linked recessive inheritance pattern, sir. He was asking why it is not mitochondrial inheritance.
Dr. Madhumita, sorry for the interruption. Actually, next
Yes,
week,
sir.
at the same time, now we are having 8:30 to 10 o'clock. And next Saturday, we are having OSCE session, whatever the leftover. Okay, that's why I want to inform you. Okay. Yeah, please proceed.
Mitochondrial inheritance mainly based on the clinical features only because X-linked recessive, most of the conditions are familiar to us. And most of the time in mitochondrial inheritance, we may not be able to prove it, even though it is possible, we may not be able to prove it. But in X-linked recessive, we may be able to prove it because there are clear-cut conditions, which I mentioned earlier, like DMD and other conditions. I think Saravanan has mentioned about the osteopetrosis, methemoglobinemia.
Yes,
These are all, I think most of you are familiar with this. Hypocalcemic tetany, Mobitz type 1. 1 minute.
If given
Joubert syndrome also you answered. Lissencephaly.
yes, the next question is
What is
if given within 3 months previous, irrespective of the vaccination date, we can give for the rabies vaccination.
Here again, there are little confusion. Sometime it mentioned even in the vaccinology book, beyond 3 months, only 2 doses. And before 3 months, there are some different things. Beyond 3 months, only 2 doses. For any, irrespective of the time duration, only two doses without immunoglobulin.
Sir, is it must to go through Nelson images for DNB practicals?
Very, very important because mostly Nelson and Pius Gupta, these are the 2 books mostly because suppose I am setting a question, I don't want to make a mistake means I always depend on a standard book. Take a standard book picture and then present it so that the person who sets the examination will not get into problems. So mostly.
Can I also add this?
Yes, sir, definitely, sir. Definitely, sir.
Yeah, it is already mentioned in the DNB. Just to see whether you people are familiar with reading Nelson.
Textbooks.
So many times it is being taken with the copyright taken this thing. So kindly go through all this thing, pictures and keep in mind, because most of the questions, in case people who are having not much of clinical practice, they may not get from this thing appropriate pictures. So now, of course, with video, cell phone, etc., most of them are bringing their own. But better be familiar with Nelson because you'll be able to answer at least 20% of the pictorial this thing. Okay.
Nowadays, more questions are taken from Pius Gupta, sir, because it is about and most of when we read it, usually we skip the tables, pictures, formulas. So there, all our OSCE questions are buried in between the text only. So you concentrate on tables, flow charts, pictures. From there only all the OSCEs are taken. And
sorry for interruption, sir. Actually, they're taking a lot of videos, as you said, the cell phone and what are the clinical practice, they're taking videos. But also nowadays they are displaying in the OSCE. Another thing is, sir, you said no, the cyanotic spell, no injection propanol. It's not available, sir. That's a esmolol. You can go for esmolol.
Esmolol. Nowadays, esmolol is used.
Yeah, 0.1 milligram per kg. We can use it, sir.
Safer also than propanol, I think.
Yes,
Then one comment is in Paul, there is a line mentioned for all series 15:2 is the best. But for 15:2, ventilation compression is not, it's a difficult one for a single person. From moving from ventilation to compression, for the sake of convenience and ease for the single person, it is given as 30:2. Once a 2-person, 2 rescue team is there, it 15:2 becomes easier. Even though it's good for the child, it's difficult to perform in a single person. That is why.
What about ketamine? Ketamine is mentioned.
Ketamine is also used. Ketamine is also used.
Some of the books are mentioning, yeah.
Okay. Sir, anything, sir, please?
That's also.
So maybe in the chat box, you can quickly post what ask is which we have not shown you, what you want, so that we can prepare and add to that. Illa Rajendran?
Yes, sir.
They can quickly.
Wide coverage. So you have done wonderful.
Yeah, it is available.
Sir, anything which anything you want it probably post in the chat box.
So it is nowadays it is available in the IAP TNC YouTube channel also. And they can go for they can see that on whatever today conducted program. And I think next week same time we are having 8:30 to 10 o'clock we are having same presentation. I think whatever leftover questions we can cover, sir.
The tetany video did not play well. I'll show it in the next session.
Okay, sir.
Okay. So
yeah,
sir,
we had shown a coach's hand in a newborn.
Pardon,
yeah, a coach's hand in a newborn hypocalcemic tetany. Of course, here, of course, it is a tension. Of course, one can make out the flexing and extending the fingers. Yeah.
So on behalf of IAP TNSA, I thank Dr. Thangavelu sir and Dr. Madhumita and Dr. Srinivasan sir for his expert comment also. And really it's worthwhile. I think more than 250 postgraduates attended today's program. And really it's a great honor and really thankful to Dr. Thangavelu sir for his effort. And Dr. Thirumurugan, please.
Mainly, the very teacher learns. Sir, Srinivasan sir, we learn first.
Energy and enthusiasm is wonderful.
The best person benefited will be the person who teaches. He'll be the beneficiary.
Even when I go in his car, he will be showing so many cardiomyopathy of vitamin D deficiency. I came to know first time when I was traveling to Mehta Hospital with him from Tiruvallur.
Thank you, sir. Anyhow, I also personally thank Dr. Madhumita for producing a wonderful
wonderful.
Madhumita, you are blessed by a great teacher, sir.
Thank you, sir.
Dr.
Thank you, Thirumurugan and Rajendran, for arranging.
Thank you very much, sir.
Very good.
Yeah.
So, actually,
1.5 hours, 90 minutes on the flow.
Time sir.
Speed, tired, sir. Really wonderful, sir. Really happy.
Sometimes it drags on sir, actually.
Because of
sir. Okay, great.
Thank you very much, sir.
Thangavelu teaches, nobody can wink the eye also.
Sir, please, sir. Thank you, sir.
Thank you very much, sir,
for
having teaching all the people, actually. And then hope we'll see you again next week, sir. So thank you very much. And,
thanks, sir.
All your
before you close, I'll just see anybody has posted asking for any.
Yes, sir.
Note
yes, sir. Infectious disease instruments.
Thank you. Instrument and
instruments and other things, tubes and other things. Everything cannot be covered in one session. So yeah.
Okay, sir. Good night.
The students should thank the IAP TNSC for organizing this in a short time.
Yeah.
Thank you, sir.
Yeah, worthwhile this thing. Yeah. That will bring more people into post-graduation and pass percentage will increase. Thank you.
Thank you, sir.
Thank you, sir. Thank you, sir.
Good night, sir. Good night, sir.
Thanks.